Reporting and responding. At 2300, we were called to a 19-year-old male who has altered level of consciousness, intoxication, and suspected to have had a seizure. Code 1. On arrival, it was obvious to see that the residence was having a party. The patient was found in the backyard of the residence on the grass on his side, vomiting, coming in and out of consciousness. There were intoxicated persons surrounding the patient, so crowd control was necessary. The patient was alert to pain and conversed normally when alert, GCS of 13. Due to his altered level of consciousness, the patient's partner answered our questions. The partner said the patient fell in the bathroom and hit his head on the toilet seat and had a seizure. All vital signs were adequate. A neurological and head-to-toe assessment was completed. The stair chair was required to maneuver the patient to the ambulance due to inadequate room for the stretcher through the house. Once the patient was in the ambulance, IV access was gained and off to the hospital we went. Relating. As patient care, there were limitations to my length of study, like administering sodium chloride through IV access. This was administered due to the nausea and the inability to hold down oral fluids. I also have no training in using a stair chair. Due to the nature of the case, a neurological assessment was performed, as the partner stated that he hit his head and had a seizure. His pupils were equal and reactive to light with a good pupil size of 4 mm. He had adequate motor and sensory function, but his speech was slurred. We believe that this was due to his intoxication. This case, especially on weekends, is quite common in this profession. The conditions are similar, in which the patient has drunk excessive amounts of alcohol, crowd control was needed, vomiting, team lifting and maneuvering, and IV access. I have most of these skills for this case. Reasoning. The significant factors of this incident were the level of intoxication and the suspected seizure. All of the vital signs were in the required range, neurological assessment was fine, and his head-to-toe examination showed no bumps, lumps, bruises, abrasions, or lacerations, which would indicate no fall. Curtis and Ramsden, 2011, Emergency and Trauma Care for Nurses and Paramedics, specified that cervical collar immobilization, if suspected acute cervical injury, should be administered. Due to him walking from the bathroom to the backyard, all assessments and examinations and discussion with my mentors, no cervical spine immobilization was required. They believe that due to his restlessness, levels when he was conscious would irritate him and would be difficult to reason with him to stay still. No OPA or NPA were needed, as the patient was breathing adequately and administering these would irritate his vomiting. The patient has no history of seizures, however has a history of head injury from BMX. There were no postictal symptoms of a seizure and all neurological assessments were clear. Paramedics carrying a drug called midazolam that is used for patients experiencing seizures. According to betterhealth.gov.au, midazolam is a type of benzodiazepine which causes sleepiness, muscle relaxation, and short-term memory loss. However, BetterHealth also noted that midazolam cannot be administered if patient is highly intoxicated, as it can enhance the patient's current symptoms. Reconstructing. If I were to reconstruct this event as a primary officer, I probably would have used a cervical collar, considering the patient supposedly hit his head on a toilet seat. Even though there were no signs of a fall, I would have applied it just to make sure. However, a technique of 2 rolled towels placed either side of the patient's head was used by my mentors to stabilize and immobilize head movement. Girling M., Davis D., Hamilton R., and Morris G., 2000, effects of cervical spine immobilization technique and laryngoscope blade selection on an unstable cervical spine in a cadaver model of intubation, state that this is a suitable technique to use. Crowd control, which one of my mentors performed, is an aspect that we are taught. However, it is different in real life situations. The whole time myself and another mentor were asking questions and retrieving vital signs, she was controlling the crowd and making sure that intoxicated persons were not delaying our treatment. This will be something I need to work on. There was room for improvement as I didn't check the patient's perfusion or respiratory assessments, and my line of questioning could have been much more concise. Thanks.